Welcome to the Monroe-Livingston County EMS Continuing Education presentation on sepsis and distributed shock. My name's Dylan Morris, and today I'm going to be covering this relatively common but underappreciated pre-hospital topic. Before we get started, I want to thank each and every one of you for everything you do every day. It matters. The learning objectives for today are as follows. First, be able to recognize the SIRS criteria, the Systemic Inflammatory Response Syndrome, which we'll cover in much greater detail later. Second, to define the stages of sepsis and understand its progression. Third, to recognize and initiate treatment of severe sepsis in the pre-hospital setting. Fourth, to understand distributive shock in sepsis and the pathophysiology that underlies hemodynamic instability in sepsis. And finally, to familiarize yourself and know the new Melrem sepsis protocol. I'm covering sepsis today in order to increase awareness of the syndrome and the vital signs associated with it, in order to reduce unnecessary deaths, such as that of Rory Staunton. He was an 11-year-old boy who got a small cut on his arm after he fell playing basketball. He went to bed that night and woke up the next morning with a small cut on his arm and a little bit of surrounding redness. Throughout the day, he began to feel a little bit worse, developing nausea and vomiting, and was taken to his pediatrician. She diagnosed him with gastroenteritis. He went home but continued to do poorly through the evening, and his parents took him to the emergency room that night. He was diagnosed as being dehydrated, given some fluids, and sent home, despite noticing there that he was hypotensive, tachycardic, and febrile with a clear source of infection. The following morning, his parents found him difficult to arouse. He was covered in purple splotches and barely communicative. He was rushed back to the emergency room and admitted to the intensive care unit, where he died 24 hours later. The signs of sepsis were clear, but no one recognized them, and Rory died a preventable death, something that we hope through this presentation we'll be able to prevent in the future. The first thing to know about sepsis is that it is not a disease. It's a syndrome, a constellation of symptoms. It's the end result of a dysregulated but normal immune response. A person doesn't get sepsis. Rather, sepsis is secondary to another injury or insult, and is the result of the body's attack on that first insult, usually an infection. But to talk about sepsis is to start at the middle of the conversation. To understand what's really at play, we need to understand the continuum between healthy and dead, where sepsis fits squarely in the middle. So to start, you, today, are a healthy person. You suffer some form of insult, a cut, pneumonia, a urinary tract infection. As your body begins to fight this infection, your immune system ramps up. Occasionally, the insult becomes very large, or your response to that infection becomes too large, and you go from having a local immune response at the site of the infection to a systemic one that courses through your entire body. At this point, you're likely to meet the SIRS criteria, the Systemic Immune Response Syndrome. SIRS criteria plus a likely infection equals sepsis. That's it. Sepsis is simply SIRS plus an infection. From SIRS, we progress to severe sepsis, usually with some evidence of end organ dysfunction. That could be altered mental status, poor urine output, hypotension, or several others. Septic shock is the next stage in this continuum, and is defined as hypotension that does not respond to fluids. Unfortunately, septic shock is followed by multi-organ dysfunction and ultimately death. Mortality at this point is very high, so identifying and treating patients earlier in the SIRS and sepsis and even severe sepsis stages is crucial. A local insult causes inflammation. This you know and understand intuitively from everyday life. A cut, a bruise, a broken bone, or a deeper infection. It's perfectly normal and healthy to have a local inflammatory response. It's how we take care of an injury or an infection. Each of these components you know from your own daily life. The first is redness. As the small blood vessels dilate, allowing increased blood flow and small molecules that help to heal the area, it turns red. You know this from every time you've ever gotten a cut. Next is tumor or swelling. Capillaries become leaky, allowing immune cells and fluids to migrate out towards the injury, helping to repair it. But this also causes the local swelling that we all recognize. Dolor, or pain. This is meant to be protective. It's our body's way of saying, "You broke your ankle, you fool. Don't walk on it." Heat. Areas of inflammation are often warm to touch for the same reason that they're red. Increased blood flow through vasodilation. And finally, loss of function. You've hurt the area. It's in pain, mostly because of all the immune response that's happened, and the tissues in that area at a molecular level become unable to perform their normal duties. This all gets better over time, and it's all perfectly normal and part of the healthy immune response system. But one can understand that if this response goes from being local at the site of your broken ankle to your entire body, it could cause significant and even life-threatening or life-ending problem. Several times already we've alluded to the SIRS criteria, the Systemic Inflammatory Response Syndrome. And if you take nothing else from this talk, I want you to remember and memorize these 4 criteria. These are the cut points for identifying a patient who is likely to be septic. First is temperature. Temperature greater than 38 or less than 36. In Fahrenheit, that's 100.4 or 96.8 degrees. Patients may be cold or warm. The young and old particularly are more likely to be cold because they vasodilate and shed heat, but don't end up with a good febrile response, a good shivering response. The next criteria is tachycardia with a heart rate greater than 90. Please note that this is 90, not the 100 we usually think about for tachycardia. Also consider patients who are beta blocked may be relatively tachycardic. The third criteria is a respiratory rate greater than 20 or an end-tidal CO2 less than 32. And the fourth criteria is white blood cell count greater than 12,000 or less than 4,000. Clearly in the pre-hospital setting, this is less useful than the other 3, but with the rise of urgent care in our area, I think we'll see that we have this data point more often than we have in the past. Also note that hypotension is not part of the SIRS response. It's an ominous sign found much later in the sepsis progression. In order to meet SIRS criteria and thus potentially be septic, you must meet any 2 of those criteria. Temperature greater than 38 or less than 36, heart rate greater than 90, respiratory rate greater than 20, or a white count greater than 12 or less than 4,000. Any 2 of those with a likely source of infection will make you septic. There's also a push to add a couple of extra criteria. These include altered mental status, chills with rigor, or blood glucose greater than 120 in a patient without a history of diabetes. Remember that these are all part of a normal response to an infection or an insult. And finally, these criteria are extremely sensitive but not specific, which is to say that many people will meet the SIRS criteria, but certainly not all of them will be septic. As we just stated, 2 SIRS criteria plus an infection equals sepsis. And when we talk about having an infection, think about having a very low threshold to suspect infection. It doesn't need to be diagnosed, simply that a cut that looks red and hot, a woman who tells you it burns when she urinates, or hearing junk in the right lower lobe of a lung should make you think that this is an infection. That's it, a very low threshold to suspect infection. So where does sepsis come from? The most common source is a pneumonia, and the most common of these is an aspiration pneumonia, often in the right lower lobe, though certainly it could come from any form of pneumonia. The second most common source is urinary tract infection. This is most common in women, but consider it in any patient who requires frequent or has had recent catheterization. Finally, patients with any sort of indwelling foreign body or recent surgery. These patients are at very high likelihood to develop an infection, usually in the 5 to 10 days out from surgery or foreign body insertion time frame. And who develops sepsis? Most commonly, the elderly. The immune system does not function as well when we age and predisposes the elderly to more serious infection. The very young, particularly those under 2 or 3 months of age, are often at high risk for sepsis and are considered septic with only a fever alone. Finally, the immunosuppressed population is at very high risk for overwhelming and massive infection. Immunosuppressed patients include HIV and AIDS patients, those patients with cancer on active chemotherapy, and those who require chronic steroids. This diagram shows, at a molecular level, the pathophysiology of sepsis. While this is well beyond what you need to know for EMS, the takeaway points here are that there is a pro-inflammatory and an anti-inflammatory response to an infection. Unfortunately, the pro-inflammatory response often wins out, causing much local cell damage and dysfunction. The anti-inflammatory response that survives, unfortunately, causes immunosuppression, making a secondary infection more likely. Together, this creates a particularly perilous situation in which local cell death results from pro-inflammatory response, and you're more susceptible to severe infection later on. This slide details, at the molecular level, the result of that pro-inflammatory response, which ultimately causes tissue hypoperfusion. This becomes important later when we talk about hemodynamic instability as the cause of death in septic patients. Takeaway points here are that blood vessels dilate, causing a decrease in blood pressure and also a decrease in red blood cell functioning. This causes tissues to become hypoperfused and poor tissue oxygenation, causing organ failure. The pro-inflammatory response also causes dysfunction of vascular barriers, leading to capillary leak and interstitial edema. Water exits the blood vessels and enters the surrounding tissues, just as we saw in a local inflammatory response. Finally, there's a decrease in anticoagulation and an increase of procoagulation. This causes thrombi to form in the microcirculation, causing plugging in the capillaries where oxygen is meant to exchange in the tissues. All told, this leads to dramatic tissue hypooxygenation and end organ damage and failure. After sepsis, the next step in the progression is severe sepsis, which is simply defined as the addition of end organ dysfunction. Most commonly, we talk about hypotension with a systolic blood pressure less than 90. Other criteria would be altered mental status or oliguria, poor urine output. Finally, lactate greater than 4 should be considered a panic value for severe sepsis. We'll talk more about lactate later, but suffice to say for now that lactate is a measure of poor tissue perfusion. You can see that hypotension, altered mental status, and oliguria are simply ways of defining end organ dysfunction, either blood vessels, brain, or kidney dysfunction. Any similar criteria that you can think of would probably meet criteria for severe sepsis. The final stage of sepsis after severe sepsis is septic shock, which is defined as hypotension after adequate fluid resuscitation. Hypotension in this case is a systolic blood pressure less than 90 or a mean arterial pressure of less than 65. Adequate resuscitation is 2 liters or more of fluid. Again, septic shock is simply hypotension not responsive to 2 or more liters of fluid, and it carries a very grave prognosis. Now that we've covered the stages of sepsis, let's back up a little bit and talk about why Why does this matter? Most importantly, there's 750,000 cases of severe sepsis every year in this country alone. It accounts for 2% of all hospital admissions and 10% of all ICU admissions. It's approximately 25% fatal at the severe sepsis or septic shock stage and accounts for about 200,000 deaths per year. In total, sepsis kills more people than breast, lung, and prostate cancer combined every year. That's why we're talking about sepsis. So, sepsis is bad. Still, what's the big deal? First, EMS can make a difference. Early identification and treatment saves lives. In fact, mortality is increased by 7.5% every hour antibiotics are delayed. A patient who spends 3 hours in the waiting room instead of receiving antibiotics has a nearly 25% higher chance of dying. This means that advocating for your patient who you believe is septic to receive adequate early treatment is extremely important. Simply mentioning this at triage may make the difference between life and death for certain patients. We alluded to the fact that it's not usually the infection, but rather the consequences of the infection that kill patients. So what are the major consequences? This is a normal chest x-ray. See how it's very clear? There's no white patchy areas, there's no pneumonia, there's nothing wrong with this chest x-ray. Compare it now to this chest x-ray, in which you see white opacification, fluffy densities in almost all fields of the lung. This is acute respiratory distress syndrome. It's one of the most feared complications of sepsis and carries a very high mortality. As tissues and vessels become leaky, fluids enter the lungs, causing these patchy bilateral infiltrates. As a paramedic or an EMT, you'll hear diffuse, poor lung sounds. This is a patient who will ultimately require intubation in order to survive, but probably should not be intubated in the field in the absence of other clear indications. Just to be clear, this is not the result of fluid overload. In fact, studies have demonstrated that aggressive early fluid resuscitation is protective against ARDS. All patients who you suspect of having severe sepsis deserve fluid resuscitation. In the earlier vignette of Rory Staunton, we spoke about him awaking covered in purple patches. Those would have been similar to the picture above. This is disseminated intravascular coagulation. We mentioned in the pathophysiology slide about microvascular clogging or clotting. This is a visual representation of what that slide showed. Capillaries become clotted off and can no longer adequately supply tissues. What you see happening at the skin level is also happening at the level of the organs, and critical organs are being underperfused. This is a very late finding in sepsis and carries a mortality in excess of 50%. Finally, it's shock that kills patients. More than anything else, hemodynamic instability and shock kill septic patients. Shock is not defined as hypotension. Rather, it's defined as inadequate tissue oxygenation. Usually it's poor circulation or poor perfusion that causes shock, but not always. Simply remember that inadequate oxygen supply to tissues which require oxygen to survive is shock. We spoke briefly about lactate, which is actually a proxy measure for tissue oxygenation. Lactate is created when oxygen does not adequately supply tissues that require oxygen to make energy. Lactate greater than 4 is an indication of severe sepsis and severe tissue hypoperfusion. In the hospital, we trend lactates every hour to determine whether patients have been adequately resuscitated or not. It's likely that in the future, you'll see greater use of pre-hospital lactate meters, though to date, their use is simply experimental and has not been proven. There are many types of shock, and it can be confusing to look at them all without an organized system. For me, the easiest way to talk about shock is to talk about the circulatory system as plumbing. There's a pump, there's pipes, and there's fluid, and dysfunction at any level of the plumbing, either a bad pump, leaky pipes, or not enough fluid, can cause inadequate circulation, which results in poor oxygen delivery and thus shock. With that framework established, we can actually categorize shocks in a way that makes sense. Cardiogenic shock is pump failure. We see this in patients who are having heart attacks, tamponade, tension pneumothorax, or massive pulmonary embolism. Distributive shock is dysfunction of the pipes. This is what we see in sepsis or anaphylaxis or in some types of neurologic injury. And finally, hypovolemic shock is simply a lack of fluids. We see this most often in trauma, but also in burn patients and patients with severe pancreatitis. Obviously today we'll be talking about distributive shock. Why a picture of feet? Well, normally when we think about shock, we think about cool, clammy extremities. And this is an adaptive response. In cardiogenic or hypovolemic shock, our body clamps down the blood vessels that supply less critical areas of the body. Particularly, this includes fingers and toes, which are a lot less important than your heart and brains. However, in distributive shock, blood vessels dilate, causing hypotension, leaving warm, well-perfused fingers and toes. In a patient who is hypotensive but has warm extremities, consider distributive shock, and in this case, sepsis, as the cause of their hypotension. Since it's the hemodynamic instability that causes much of the mortality in septic shock, let's spend a minute talking about the hemodynamics. The first concept to understand is stroke volume, which is simply end diastolic minus end systolic volumes. So breaking that down, the left ventricle fills during diastole and then is pumped into the rest of the circulation during systole. So stroke volume is really just the total amount of blood that started in the heart minus the amount of blood that was left over in the heart. It's that simple. There's a few factors which contribute to varying levels of stroke volume. The first and most important factor is preload. This is the end diastolic volume. The amount of blood that begins in the heart is the most important factor in determining how much blood is pumped into the rest of the body. The second most important factor is afterload, or blood pressure. If the heart has to pump against a very high blood pressure, it's very difficult to get blood out into the circulation. So a high blood pressure will reduce stroke volume. Finally, contractility is important. Even with a very good low blood pressure, a heart that doesn't contract adequately, that doesn't squeeze adequately, will not be able to maintain a large stroke volume. Normal stroke volume in a healthy adult is approximately 70 milliliters. We just mentioned that preload is the most important factor in determining stroke volume. The reason for this is Frank Starling's law of the heart. Basically, what it says is that the heart muscle is like a rubber band. Stretch a rubber band just a little bit, you get only a small recoil. Stretch the rubber band vigorously, you get a big recoil. The heart muscle's the same way. You fill the heart with a lot of fluid and it will contract very vigorously. You fill it with just a little bit of fluid and it will have a difficult time contracting adequately. Thus, high end diastolic volume is very closely associated with high stroke volumes. This is the reason why fluid resuscitation is important in patients with septic shock. These patients have pathophysiologically low end diastolic volumes and thus low stroke volumes. If we can add fluid to the tank, they'll be able to increase their cardiac output through higher stroke volumes. Cardiac output is just heart rate times stroke volume. It's the word for how much blood is pumped through the heart in 1 minute. The normal healthy adult pumps about 5 liters of blood per minute. The next topic is MAP, or mean arterial pressure. That's the number that gets displayed on our monitors, but we pretty much ignore. But it's actually incredibly important during distributive shock. The reason is this: cardiac output times systemic vascular resistance equals MAP. You spend about 2/3 of your time in diastole and only 1/3 during systole. And most importantly, very few of the vessels in your body actually ever see systolic pressure. And certainly all of the blood vessels which are responsible for oxygen exchange, like capillaries, never see systolic blood pressure. All they see is an average pressure in the vessels. A good systolic pressure, but a very low diastolic pressure, often still means a patient is in shock, because 2/3 of diastolic blood pressure contributes to MAP and only 1/3 of systolic pressure. Normal MAPs are 80 to 110 in most adults. A MAP of less than 65 is a non-perfusing MAP. It is simply not high enough to supply adequate tissue oxygenation. That covers the basics of hemodynamics in shock. Let's move on to therapeutics. The first studies looking at therapeutics in shock were done with dogs. These dogs were injected with E. coli into their abdomens and then waited until they became very ill. They were randomized into 4 different groups. The first group received no treatment at all. The second group was given antibiotics. The third group, hemodynamic support. And the fourth group, antibiotics along with hemodynamic support. Mortality in the first group, without any treatment, was 100%. All of the dogs died. In the next 2 groups, those that got antibiotics alone or those that got hemodynamic support alone had a 97% mortality. But in the group which received both antibiotics and hemodynamics together, only 87% of the dogs died. 13% survived, a dramatic improvement compared with the other 2 groups. While not seemingly astounding, this has been the basis on which we've treated sepsis ever since. As sepsis research evolved and our understanding of the out-of-control inflammatory response developed, numerous drugs were developed in an effort to control that pathophysiologic inflammatory response. Unfortunately, in all of the 30 years that we've been studying sepsis for, only one single drug has ever made it to market, and that drug, Xigris, was voluntarily removed from the market just a few years after its approval. At $5,000 a dose, one would have expected that it wouldn't have caused increased mortality in patients treated with Xigris. The FDA was on the verge of revoking its approval for market when Eli Lilly voluntarily withdrew it from worldwide circulation. Neither before nor since has there ever been a drug which has been clinically useful in modifying the underlying disease process in sepsis. What we're left with today is simply antibiotics and hemodynamic support, no better than when we were in 1981 studying E. coli in the abdomen of dogs. In the same year that Xigris was approved, 2001, Manny Rivers and his team at Detroit Receiving Hospital published this landmark study called Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock. This was a landmark paper which established very formal protocols for optimizing hemodynamics in sepsis and beginning treatment for sepsis, not in the ICU, but rather in the emergency department shortly after patients arrived. Using his protocol, he showed dramatic improvements in patient outcomes, reducing mortality astronomically. This paper fundamentally changed the way sepsis was treated in both the ED and in the hospital at large, and has had an incredible impact on the treatment of sepsis ever since. In the years since the Rivers trial was published, there have been numerous critiques of the Rivers protocol, and the goalposts of early goal-directed therapy have become less clear. The Process trial, published in March of 2014, showed that invasive monitoring with a very strict protocol, such as the Rivers protocol, was not necessarily better than a less invasive protocol, or in some cases, no protocol but standard care alone. That said, the difference Rivers trial made cannot be underestimated. Simply, the goalposts established by early goal-directed therapy are not clear today. What we do know as a result of many, many trials published over the last 2 decades is that early therapy makes a difference. The goals are unclear, but early therapy with early antibiotics and early fluids make a difference. And this is something that EMS can contribute mightily to. As a quick reminder of the most important part of this presentation, severe sepsis is defined as a temperature greater than 38 or less than 36, a heart rate greater than 90, a respiratory rate greater than 20, and a white count greater than 12,000 or less than 4,000, plus signs of end organ dysfunction, meaning hypotension, altered mental status, low urine output, or a lactate greater than 4. Remembering these criteria and making sure that those patients receive early fluids is the most important thing that we can do in EMS to save lives in sepsis. Quickly, initial fluid bolus in most hospital protocols calls for a 30 cc per kilogram fluid bolus. That means 2 to 3 liters, mostly as quickly as possible. Establishing 2 large bore IVs and opening the fluids wide is important. I would reassess for lung sounds and signs of fluid overload every 500 cc's, but these people require massive amounts of fluids. In our ICUs, patients often are net positive 20, 30, and up to 50 or 60 liters of fluid. The 2 to 3 liters given in the field maximum is simply the beginning of their therapy. Septic shock, remember, was defined as hypotension not responsive to 2 liters or more of fluid. These patients require additional blood pressure support with vasopressive agents. Norepinephrine is now the treatment of choice for pre-hospital hypotension. It is also the treatment of choice as a vasopressor in the hospital for patients with septic shock. Without belaboring the point any further, consider norepinephrine to be the treatment of choice for refractory septic shock after fluid administration. The final study I wanted to talk about today is also hot off the press. Published in the summer of 2013 in the Journal of Emergency Medicine was this study in Denver of pre-hospital detection and treatment of patients with severe sepsis. Termed the Denver EMS Sepsis Protocol, they used a system which looks very much like what we've talked about today to identify sepsis. Temperature greater than 38 or less than 36, tachycardia greater than 90, a respiratory rate greater than 20. So any 2 of those criteria, plus a presumed or likely infection, plus a criteria making you severe sepsis, meaning hypotension with a systolic pressure less than 90, or a MAP less than 65, or a lactate greater than 4. Once you met those criteria, you were moved into the EMS sepsis protocol, which called for the establishment of 2 large bore IVs, a 20 cc per kilogram fluid bolus, and contacting medical control for further orders if systolic pressures remained less than 90 after the fluid bolus. Part of this protocol was to treat sepsis just like we do here with an MI or a stroke. It required pre-hospital notification, which triggered a series of events inside the hospital. The equivalent of a trauma bay room was made available. Antibiotics were ordered for the pharmacy and were available at the time of arrival at the hospital, and the ICU team was notified. A bed in the ICU was made ready, and the ICU team was at the bedside when the patient arrived at the hospital. All of this reduced their time to antibiotics to under 20 minutes in most cases. But did it make a difference? As you can see from this chart, patients who were randomized to receive pre-hospital notification for sepsis did much better than similarly matched patients who did not receive pre-hospital notification. Mortality among those who met sepsis criteria but did not have pre-hospital notification had a 1 in 3 chance of dying, 33%. Those similarly matched septic patients who did receive pre-hospital notification had only a 13.5% chance of dying. That meant their odds of surviving were approximately 3 times greater than those not receiving alerts. This was only a pilot study, and it's my personal feeling that the effect shown here is probably greater than will be shown in a final study. The effect is simply too large. That said, I do believe that pre-hospital notification and pre-hospital treatment of sepsis will be shown to be effective and life-saving, and will certainly be following the results of the final Denver Sepsis Protocol papers when it's available.
Early recognition and early management of sepsis is important in optimizing the outcome for our patients. Just as we have initiated early recognition and transport and treatment protocols for stroke and STEMI, MilREMS has now instituted a sepsis protocol to optimize the recognition, the treatment, and the management of patients with sepsis. A patient is included in this protocol when they exhibit all 3 of the following: a suspected infection. This could be a urinary tract infection, postoperative infection, pneumonia, or cellulitis, along with hypotension defined as a systolic blood pressure of less than 90 or altered mental status, and at least 2 of the following: either a heart rate of greater than 90 beats per minute, a respiratory rate greater than 20 breaths per minute, or an end-tidal CO2 of less than 32 millimeters of mercury, a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius if that temperature is available, and lastly, a white blood count of greater than 12,000 cells per cubic millimeter, less than 4,000 cells per cubic millimeter, or greater than 10% bands. I recognize that in most circumstances we will not have temperature and white blood count information. However, sometimes we may, and we can utilize this information to further care for our patients. Once you've identified a patient with sepsis, you should provide your routine medical care and assure airway patency, administer oxygen per our protocol. If not done already, you should continue to assess your signs, symptoms, and history of present illness and the medical history. And lastly, you should begin timely transport in a supine position if the patient exhibits signs or symptoms of septic shock. Most importantly, the patient should be kept warm, including a warm ambulance compartment temperature, but you do not want to induce hyperthermia. At the paramedic level, you should establish large bore vascular access and administer 2 liters of normal saline. Large bore is generally greater than an 18 gauge IV catheter. 14 or 16 gauge is desirable. You should still obtain a blood glucose and, if available, a serum lactate. You should consider second large bore intravenous access depending on the patient's vasculature and time. And you may continue aggressive fluid maintenance beyond 2 liters of normal saline, even if the patient presents with normal vital signs, provided their lung sounds remain clear. So again, provide aggressive normal saline fluid resuscitation, but continually monitor their respiratory status and their vital signs while doing so. If after 3 liters of fluid resuscitation, the patient's systolic blood pressure is less than 90, you may consider norepinephrine 2 to 20 micrograms per minute titrated to maintain a MAP of greater than 65 millimeters of mercury. If patient meets any of the above criteria, meaning a suspected infection with hypotension or altered mental status, and at least 2 of the following, including a heart rate, respiratory rate, temperature, or white blood count in the parameters noted in the protocol, you should contact the receiving hospital and indicate that you have a sepsis alert and provide the appropriate clinical information as you normally do. Let's look at a brief case in terms of how we might apply the MilREMS sepsis protocol. You arrive to find a 63-year-old female dispatched as a priority 3 sick person on a Saturday afternoon. She has a past medical history significant for diabetes, hypertension, and coronary artery disease. 5 days ago, she underwent hernia repair. She had an uneventful hospital course and was discharged on postoperative day 2. She wasn't feeling well on Thursday night. She discontinued her pain medications on Friday and there was no improvement in her condition. She's very weak. Family became concerned and called 911. As you assess her, you identify that her pulse is 92, her blood pressure is 102/40, her respiratory rate is 22, and you happen to have the ability to obtain a temperature, and it is 35.6. What you also find is that she has been somewhat aphasic since about Thursday and has not been speaking normally. This case could be confounding in that she has some aphasia, so maybe we would think about stroke, but she also has the potential for a postoperative surgical infection. As we look at her vital signs, her blood pressure does look soft, but not so bad at 102. But if you calculate her MAP, you realize that her mean arterial pressure is actually 60, which is very low and non-perfusing. Remember that any time you have a MAP of less than 65, that should make you worry, and you should consider giving fluids. In this case, her heart rate is 92, her MAP is 60, her respiratory rate is 22, and she is slightly hypothermic. So she actually meets 3 out of 4 SIRS criteria. One could argue that given her aphasia, she even has some mild altered mental status associated with that. And she does have the potential for an infection given her recent hernia repair. This patient, if possible, should receive large bore intravenous access and begin aggressive fluid resuscitation on the assumption that she has sustained a postoperative surgical infection. Keep the patient warm during your transport to the hospital, alert the receiving hospital of a possible septic patient, and continue your transport. Through this presentation from Dr. Morris, we've identified SIRS criteria, which is a suspected infection with at least 2 of the following: a heart rate of greater than 90 beats per minute, a respiratory rate greater than 20 breaths per minute, or end-tidal CO2 of less than 32, a temperature of greater than 38 degrees Celsius or less than 36 degrees Celsius, or an abnormal white blood count. We've also reviewed and provided you with information to understand the pathophysiology of sepsis and why it is so important to recognize sepsis and begin treatment early. You should recognize and initiate the treatment of severe sepsis, which is a patient that meets SIRS criteria and has hypotension or altered mental status. So again, to clarify, a patient that meets just SIRS criteria would not qualify for this protocol. However, a patient that meets both SIRS criteria and hypotension or altered mental status will be entered into this protocol and should receive aggressive fluid resuscitation utilizing the Milrem sepsis protocol.